And now, may I invite my dear colleague, Dr. Mohamed Abo to talk to us about glaucoma evaluation after refractive corneal implants. Dr. Mohamed, please.
Good evening, everyone, and I would like to thank the organizing committee for inviting me to speak about this topic, which give me a rare opportunity to expand my little knowledge about the cornea. So, what are the refractive corneal implants that we know? The first corneal refractive implant was implanted and carried out by Jose Paraquer in 1949. And the law he stated back then was that when tissue is added to the corneal periphery or tissue is removed from the corneal center, flattening of the center cornea occurs. In 1966, Blabstakia tested the refractive effect of putting an implant into the corneas of rabbits using small lenses, and using that he was able to correct up to 21 degrees of myopia. Over time, it was found that making a small corneal central perforation within that implant helps with the stabilization, and hence an annual design was then adopted. Um, uh, the law using those rings says that a correction obtained using them is directly related to their thickness and inversely related to their diameter, meaning that rings of smaller diameter and greater thickness achieve better correction. In 1991, the first Ferrara ring was implanted for a patient with amblyopia and anisometropia using microkeratome to create the tunnel. But it wasn't until 2000 when Colin reported the utility of using corneal rings for keratoconus management. And he stated back then that the goal of those implants for keratoconus is not to eliminate the disease, but rather to improve the corneal abnormality so that better visual acuity could be gained and delay or elimination of the corneal graft can be achieved. Corneal refractive implants can come at different types based on the material, whether it's synthetic, PMMA, or natural, and based on the design, whether they are rings or full segments. And the indication of using these refractive corneal implants varies depending on their type. For a full lenticule or keratophakia or epikeratophakia, they are mainly used to correct higher spherical errors and to a extent to correct corneal ectasia. However, the rings or the segments are mainly used to correct corneal ectatic conditions, mainly keratoconus, post-excimer laser, corneal ectasia, and pellucid marginal degeneration. In addition, they can be used to correct post-operative corneal astigmatism, for example, post-penetrating keratoplasty or DALK or even radial keratotomy. However, they were originally designed to correct myopia, but you can see why this purpose has been largely abandoned. So how do these implants work? How can they correct or improve a corneal ectatic condition? With regard to the full lenticule, whether keratophakia or epikeratophakia, the idea is to add tissue to the cornea, thereby the cornea is reinforced and corneal flattening can be achieved, and the corneal biomechanical profile could also be strengthened. However, the ring segments act slightly differently because the idea is to induce meridional altering, and hence a corneal reshaping occurs to achieve a central corneal flattening, and this is achieved through an arc shortening effect because those implants act as a spacer element that's embedded between the bundles of the corneal lamellae. Doing that, these segments were able to improve the topographic profile for these corneal ectatic conditions by inducing an overall corneal flattening, by dislocating the corneal apex back to the center. Thereby, the corneal asphericity could be preserved and corneal irregularities can be decreased. And this could be translated clinically into improvement in visual acuity, whether uncorrected or spectacle corrected, better contact lens tolerance, and doing that, the gap or the need for keratoplasty has been delayed or even eliminated, and whether these rings can help in preventing this progression is still debatable. We will focus on the rings or the segments referred to as intracorneal stroma ring segments. So these segments have been used for a while, and the outcomes up to 5 years have been very good and encouraging their usage in many indications, as we said, and they come in different shapes and forms. And if you looked at this table or this graph, you can see that these types differ with regards to how they appear in cross-sectional, their size, their arc length, their diameter, and their optical zone. And for those who need a quick cheat sheet, Intax is the most commonly used rings. Kira rings are very effective in difficult situations. Ferrara ring is the first ring to be implanted, and the Mayo ring is a 360 degrees ring. And of note, through the different variations between those rings, all of them have an optical zone that's larger than the Goldman ablation tonometry, so the central cornea is not included typically using those implants. So as we can conclude, these implants can come in two forms of rings, whether complete or incomplete, or segments, whether one or multiple segments, and the indication or usage of each segment depends on different factors, including keratoconus staging, topographic patterns, and surgical nomograms. So how can these rings affect the corneal biomechanics? Daxter in 2015 has postulated that the myoring, being a complete ring, can divide or split the load of the IOP onto the cornea to two different circuits, and thereby creating an artificial limbus. However, the same principle cannot be applied for segments and incomplete rings because they cannot achieve the same thing. And he concluded using a mathematical spherical dome model that LASIK a corneal weakening procedure more than LASIK or PRK. However, ring segments typically they don't affect the corneal strength, in contrast to myoring, a complete ring that can improve the corneal strength, and of course cross-linking is essentially designed to improve the corneal strength. How can we measure the corneal biomechanics in vivo? There are two main devices, the Aura or ocular response analyzer, which use two air puffs to create a number of parameters, most importantly corneal hysteresis, corneal resistance factor, and IOP corneal compensated. The other device is the Corvus ST device, which acts slightly differently, and it can generate myriad of parameters, most importantly the Corvus biomechanical index and the biocorrected IOP. So using those two devices, a couple of studies have looked into the effect of these rings on the corneal biomechanics. One of them has found that after implanting them in keratoconic eyes, no difference was occurred after 1 or 3 months postoperatively. Another study used the Corvus ST found a little bit of a positive effect on the corneal biomechanics, but no difference between complete and incomplete ring. Another study that used the Aura found that corneal biomechanics did not change, whether it's corneal hysteresis or corneal resistance factors, up to 6 months after intercorneal stroma rings implantation. Another study that used the Aura found that the effect on corneal biomechanics is only transient, up to 3 months postoperatively, and it only included the corneal resistance factor, but not the corneal hysteresis. After 3 months, there was no effect on corneal biomechanics. And the last study from Brazil has used the Corvus ST device, and it found that it didn't change the corneal biomechanics early. Last study, sorry for that, used both the Aura and Corvus ST up to 24 months postoperatively, and we found that the changes were inconsistent postoperatively. So what about the effect on the IOB? A couple of studies also looked into that. The oldest of them used rabbit eyes to estimate the IOB using manometry and pneumotonometer, and they found no differences compared pre and post. Another study used Goldman ablation tonometry and tonopin and found similar findings. When a Goldman ablation tonometry is applied to the central cornea, or the tonopin applied to the central or the paracentral cornea. However, if we used a Goldman on the paracentral cornea, where the rings are there, IOB can be artifactually elevated up to 40 and 60 millimeters of mercury. Another study used 5 tonometers to compare their findings on corneal rings in keratoconic eyes, and they found that most of them were reliable, but maybe the Aura has made some underestimation. Another study, Egyptian study, has looked into pre and post corneal rings using GAT, and they found there is a mild decrease, but this decrease was neither clinically or statistically significant. Last study was also Egyptian, and it used 3 different tonometers, and they found that the differences between these devices were not consistent, and they couldn't find the correlation between them and the CCT. So, what about are there new rings? Yes, there are some new rings, allogenic rings, named the Kyres, and the other type is named the CTAK, and these are biocompatible alternatives to the synthetic intercorneal stromal rings. These have many advantages, including being more biocompatible, but there are some risk of stromal rejection, and long data is yet to be elucidated. How is that related to glaucoma? Let's speak about the disease itself, disease for which the rings were implanted. We know, and there has been proof that there is an association between keratoconus and normotensive glaucoma, and we all know how corneal refractive surgeries, including LASIK and non-LASIK, can cause glaucoma. But how the rings themselves can affect glaucoma management. In terms of diagnosis, IOP measurement can change following these rings based on changes in CCT or astigmatism or corneal biomechanics. Therapy, for example, prostaglandin analogs can cause lower CCT and alter biomechanics. Monitoring progression, because visual acuity can be improved, this can conceal subtle visual field deterioration. When it comes to surgery, angle visualization can be affected when we are trying to do a laser trabeculoplasty or for abenternomics. Even mitomycin used for trabeculectomy can affect the corneal epithelium and may expose those rings. Associated treatments including chronic cross-linking can cause high IOP measurements, and intracorneal and phakic IOLs can also cause glaucoma. And these modalities can be used in association with the rings either before or after or even concurrently. Complications: these segments are not risk-free, and although the safety profile is relatively good, some of these complications could be vision-threatening and even can cause glaucoma. So in summary, corneal rings can affect the IOP measurement, but not the true IOP in different ways, and we have to consider that these differences are not typically clinically significant, although they may be statistically significant. Corneal biomechanics don't seem to be affected by these rings, and the newer rings, including the Kyres, we don't know much about their effect on the biomechanics. Overall, when we examine a case with rings and suspected glaucoma or even have glaucoma, we need also to consider the primary cause for which the rings were implanted and other treatments, including cross-linking, that might have been used. Thank you very much.
Thank you so much, Dr. Mohammed, for this very informative talk.